to our visible body shoulder girdle talk. So in this lecture we're going to look at the shoulder girdle itself, the articulations found within the shoulder girdle, so the joints found within the shoulder girdle, obviously the bony structures, movements, and then muscles. So let's start with the shoulder girdle itself. So the shoulder girdle is comprised of the humerus, which is the longest upper arm bone in the body, the clavicle, and the scapula. So let's start at the back. The scapula is a thin, flat bone with two borders, a medial border, also known as the vertebral border, and a lateral border. It has two angles, a superior angle at the top and an inferior angle at the bottom. There's a narrow bony ridge called the spine of scapula. This divides two attachment sites, the supraspinous fossa for the supraspinatus muscle and the infraspinous fossa for the infraspinatus muscle. It has a cavity known as the glenoid cavity or the glenoid fossa. Now the glenoid fossa is situated on the lateral aspect of the scapula. It's typically pear-shaped, covered in hyaline cartilage, and in the anatomical position faces anterior-laterally and is positioned about 30 degrees anteriorly. This provides the socket for the head of the humerus to articulate with. Now the humeral head is about 4 times larger than the glenoid fossa through which it sits in. The glenoid fossa possesses what's known as a labrum or a glenoid labrum, which acts as a sucker, which is a way of reducing this size difference from 1 to 4 to about 1 to 3. Now this labrum is a ring of fibrocartilage. It's a fibrocartilage lip which is situated around the glenoid fossa itself and increases the congruency of these two bones, so the fit of these two bones, but also actually acts as a bit of a suction cap because there is a vacuum within that labral space. Now the labrum is prone to tearing, which we call a slap tear, so a superior lateral anterior postural tear. So it is prone to injury, as is this joint itself. Our final bone is the clavicle. So if you look superiorly, you can notice the clavicle slightly S-shaped. This S-shape should allow for a certain amount of force compression if falling on an outstretched arm, for example. Now the clavicle articulates with the sternum, specifically the manubrium, which is the top aspect of the sternum. This forms the sternoclavicular joint, and the ligament that keeps the sternum in place to the clavicle, known as the sternoclavicular ligament, is the only bony or ligamentous attachment that holds your arm to the thorax. Everything else is derived from the muscles, tendons, and skin. So the shoulder girdle relies on muscle, specifically scapular muscles, to maintain its stability. So the shoulder girdle itself is actually 5 joints in one region. Starting with the sternoclavicular joint, as I said earlier, it's the only bony attachment that keeps this girdle to the body itself. That's a meeting between the clavicle and the sternum. We then have the coracoacromial joint, which is a meeting between the coracoid process and the acromion on the scapula. Then we have the AC joint or the acromioclavicular joint, which is a meeting of the clavicle and the acromion on the scapula. We then have the glenohumeral joint, which is the sort of most commonly understood aspect of the shoulder, which is a meeting of the humerus, the head of the humerus, and the glenoid fossa, hence the name glenohumeral joint. It's a synovial ball and socket joint. Now moving towards the posterior aspect of the shoulder girdle, what we have is the scapulothoracic joint. Now the scapulothoracic joint is considered a non-true joint or a non-physiological joint because it's not true in the sense that it's bone on bone, it's actually bone or muscle on muscle, but nonetheless it's still considered an important joint. Now the scapulothoracic joint, as I said, is a union between the scapula and the thoracic bone. The thoracic region provides the pathway through which the scapula will move. So if the thoracic spine is malaligned, the scapula will have a poor path in which to follow and can impede movement and cause dysfunction. Now the shoulder joint itself, or the glenohumeral joint itself, is at its most stable in or the closed pack position in an abducted, externally rotated position. That's when it's at its most stable. Now the glenohumeral joint, like any ball and socket joint, is highly mobile and is the most mobile of synovial joints, but with this mobility it has sacrificed stability and is particularly unstable inferiorly and anteriorly. And a common way to subluxate or dislocate this joint is to fall on an outstretched arm or to be hit from behind, which can displace the humerus forward or inferiorly. Because of this lack of stability, it derives much of its stability dynamically through muscles. Some important glenohumeral stabilizers are called the rotator cuff, which we'll have a look at a little bit later, which are a series of muscles which all attach from the scapula to the humerus and aid stability. Now the shoulder girdle or scapula has a number of different movements that we can look at. The scapula can travel vertically, superiorly vertically, which we call elevation. It can retract, which is where the scapulae adduct and travel towards the midline. They can rotate either medially or laterally, and that's defined as where or which direction the inferior angle is traveling towards. If the inferior angle is traveling towards the midline, we call that medial rotation, also known as downward rotation. If the medial angle is traveling away from the midline, we call lateral rotation, also known as upward rotation. So as well as elevation, as I said before, they can also depress, they can protract, they can wing, which is where the scapulae lift away from the rib cage, and they can tip, which is where they flatten out against the rib cage. Moving along to the glenohumeral joint, the GH joint can do essentially the same as the hip joint in that it can abduct, it can adduct, it can flex, and it can extend. It can also horizontally extend and horizontally flex. Being a rotary joint, it can obviously rotate medially and laterally. Okay, now let's have a look at the muscles of the shoulder girdle. So we'll start with the largest and most superficial of this set of muscles, the trapezius muscles. Now the trapezius muscles are a trapezoid shape or trapezium shaped muscle of the upper back. They are divided into three distinct regions: the upper traps, the middle traps, and the lower traps. Now this muscle originates at the base of the skull, just on the occipital protuberance, and all the spinous processes from C7 all the way down to T12. That's where they originate from. Now that's their fixed attachment. Their insertion, which is always the movable attachment, inserts both just to the acromion process, the spine of the scapula, and all the way down to the medial border. So the upper fibers cause elevation of the shoulder girdle along with upwards rotation, also known as a lateral rotation. The middle fibers cause retraction predominantly, and the lower fibers cause both depression, medial rotation, and some fibers of this lower portion also cause upwards rotation. Okay, then we have a muscle called levator scapula. This muscle predominantly causes elevation of the scapula and shoulder girdle. It originates from the transverse processes of the upper four cervical vertebrae, so C1 to C4, and inserts to the medial border of the scapula just above the spine, around about these superior angles we can see there. So next up we have the rhomboids, of which we have a major and a minor. We'll group them just as the rhomboids. So they all originate on the spinous processes of the last cervical vertebrae, so C7, and the first 5 thoracic vertebrae, so T1 to T5. So that's C7 to T5, and they attach to the medial border of the scapula. Because of their oblique fiber arrangement, they cause elevation of the scapula to some degree, but mainly scapular retraction and scapular downward or medial rotation. Okay, so that just about covers the posterior shoulder girdle muscles. Let's take a look at some of these lateral scapular or shoulder girdle muscles. So next up we have a muscle group called the serratus anterior. Now these muscles have an origin of the surfaces of the upper 9 ribs, and they insert to the anterior aspect and the whole length of the medial border of the scapula. Now their concentric action is to pull the scapula forward, which we call protraction, also known as scapular abduction, and they also contribute to scapular downward rotation. Okay, looking at the front, we've got really only one front scapular muscle to consider, and that's pectoralis minor. Now, pectoralis minor attaches from the coracoid process of the scapula to ribs 3, 4, and 5. It creates or assists in protraction along with depression, as we can see its vertical fiber orientation. Okay, so let's look at some of the muscular anatomy of the shoulder joint itself. Starting with the most prominent muscle at the anterior part of the torso or thorax, we've got pectoralis major. Now, pectoralis major is a radial or fan-shaped arranged muscle. It has fibers that traverse from the clavicle, fibers that traverse horizontally from the sternum, and fibers that run off the costal cartilage of the ribs, so the immature bones of the ribs. Now they have a common insertion onto the humerus, specifically the bicipital groove of the humerus, also known as the intertrabecular groove, which is the small groove made by the greater and lesser tubercle of the humerus. This groove also is a furrow through which long head of biceps tendon will run through. So because of the distinct difference in fiber orientation of pec major, we can see how these fibers that run off the clavicle, that run superiorly to inferiorly, they would create shoulder flexion. These transverse fibers would create more of a horizontal flexion movement, and these inferior fibers which run from inferiorly to superiorly would cause adduction. It's important to note that it's still one muscle, though you might influence the amount of activity you receive in the different regions, it is still one muscle, and you will only increase the amount of activity in one, but there'll still be activity in the other two. So that's pectoralis major, originates from the clavicle, the sternum and the ribs, and inserts to the intertrabecular groove of the humerus. Okay, moving along, we're going to look at the deltoid muscle now. Now the deltoid or deltoideus is a muscle which covers the ball and socket joint of the shoulder. It has three heads: the anterior head, the medial head, and the posterior head, and they all have slightly different biomechanical movements. So looking at the anterior head first of all, that, as you can see there, attaches from the clavicle and inserts to the common insertion of the deltoid tuberosity. Because it's positioned anteriorly, it will create flexion of the shoulder and will therefore assist pectoralis major in that action. Moving to the lateral aspect, you've got the lateral deltoid, the middle head. This attaches both from the clavicle and the acromion of the scapula, and again commonly inserts to the deltoid tuberosity. And because it's on the lateral side of the shoulder, it will draw the humerus outwards and cause abduction. Moving to the posterior aspect of the shoulder, we've got the posterior head, and this attaches or originates from the spine of the scapula and inserts again to that same common insertion on the humerus, the deltoid tuberosity. Because it's positioned at the posterior aspect of the shoulder, it would create extension of the shoulder along with external rotation of the shoulder. Okay, now we're going to look at a very large muscle of the back called lat dorsi. So lat dorsi, which gives males in particular the distinct V-shaped characteristic, is a muscle which originates from the posterior crest of the ilium, the back of the sacrum, and the spinous processes of the lumbar and the lower 6 thoracic vertebrae and 3 ribs. It inserts just to the medial lip of the intertrabecular groove of the humerus. Now this muscle is originally designed for grabbing and reaching for branches and pulling ourselves up, and is quite a powerful muscle for that very reason. So this muscle is a major shoulder adductor, a major shoulder extensor, a major inwardly rotating muscle of the shoulder, and also a horizontal extensor of the shoulder. Now lat dorsi will work closely with another muscle called teres major. Some people have nicknamed this lat's little brother Terry, because essentially wherever lat goes, so does teres major. So teres major originates just on the inferior third of the lateral border of the scap, so just the bottom third of that lateral border of the scap, and inserts to a similar area of the lat dorsi, so the medial lip of the intertrabecular groove of the humerus. Because both these muscles attach to the front of the humerus, the medio-anterior part of the humerus, but actually because they traverse along the inside of the humerus, they are strong medial rotators. But teres major has the same action in that it's an adductor, an extensor, or horizontal extensor, and a medial rotator of the shoulder. Okay, we'll just move on to our smaller muscles now. We've got a muscle called coracobrachialis, which is a muscle that attaches from the coracoid process of the scapula just to the sort of medio aspect of the humerus. This is predominantly a flexor of the shoulder. Now, more importantly, what we've got is a series of muscles called the rotator cuff. Now, the rotator cuff are a group of 4 muscles, and they lie underneath the deltoid muscle group. Now, they're nicknamed dynamic ligaments, and they're nicknamed dynamic ligaments because the shoulder doesn't possess much in the way of ligamentous stability, so stability derived from ligaments, these muscles really step into the role of those absent ligaments by acting as dynamic stabilizers. Now, you may have heard of the rotator cuff being trained for people with shoulder dysfunction or injuries, and that's because they really aid the stability of the shoulder itself and are usually a neglected muscle group. Now, they all attach from the scapula to the humerus, and we'll start with the supraspinatus. Now, the supraspinatus is a muscle which sits in the supraspinous fossa of the scapula and attaches just to the humerus itself. Just specifically to the greater tubercle of the humerus. This is a shoulder abductor and works predominantly the first 30 degrees of shoulder abduction is caused by the supraspinatus. Next up we have the infraspinatus, which is attaching from the infraspinous fossa of the scapula to the same greater tubercle of the humerus. This, because of its posterior location, is an external rotator of the humerus. Next up we have a muscle called teres minor. Is pretty unrelated to its cousin teres major, other than the name teres, which is rounded or cylindrical. So teres minor originates from the lateral border of the scapula and inserts to the greater tubercle of the humerus, and follows a similar pathway to infraspinatus, and as such is an external rotator. And finally we have a muscle called subscapularis. Now this is actually underneath the scapula, hence the name in the subscapular fossa, so the fossa for this muscle. Now this inserts to the lesser tubercle of the humerus, but actually traverses along the inside of the humerus, meaning it's a very powerful medial rotator, predominantly, and also a adductor, and it provides a bit of extension. Now all four of these rotator cuff muscles, one of their major roles is to stabilize the humeral head. Now these muscles can be trained to offset the upwards and outward pull of deltoids, which can cause a reduction in the subacromial space, which is the space between the acromion and the scapula, as we can just see around here. So this subacromial arch is formed by the acromion and the coracoacromio ligament. Now this arch is a small space through which the supraspinatus tendon needs to squeeze in, long head of biceps tendon, and some other structures such as the subacromial bursa. All these structures fight for space in this small subacromial area. So the deltoid muscles can have an upwards and outward pull and reducing this space, and we can use the rotator cuff to cause a force coupled dynamic, in that the sum of all these four muscles causes a downwards and inwards force on the humeral head. Now that's all from our shoulder girdle and shoulder joint talk. I hope you enjoyed it.